Hi, this is Dr. Alice Lee. Welcome to this month's iCubed. I hope that everyone is having a relaxing summer. You're here in Arizona. Most of our snowbirds have left, and it's a bit quieter, but there's never a lack of interesting and critical cases in our mostly geriatrics emergency room. Here in iCubed, every month I present a case or two to a colleague, and we dissect the case from presentation to diagnosis and disposition, just trying to get into the mind of your everyday emergency physician out in the community, trying to demonstrate real practice of emergency medicine outside of the academic centers. This month, I heartily welcome my colleague, Dr. Jonathan Graff, whom I love to work with. Why don't you introduce yourself a little bit?
Hi, Alice. Thanks for inviting me back. Either I did something really good or really bad. So, no, it's always fun to do this, stimulating and great setup. I did my training in California, UCLA, Kern Medical Center. I've been out in practice for some time. I hate to even calculate that now. I think I'm pushing 20 years.
Oh my.
But it's still great. It's still interesting. It's still fun. And things like this really make it intriguing.
So here we go. Case number one. This is our typical average 66-year-old male. He has a history of diabetes and hypertension. He has a history of PE. He comes to the emergency department by EMS because he had fallen 3 days before presentation. He was on an out-of-town trip. He says that when he was there, he lost his balance one day while he was going down the steps. Didn't really think he hurt himself very much, so he didn't really seek medical attention. After he got home, though, he fell again today, but this time he was so weak that he was unable to get up. Okay, so his wife, his son went home. They were unable to get him up, and so they called 911. That's how come they're in your ER.
Very common.
Yes. So the wife presents to the ER with him and says he has absolutely no strength in his legs. He cannot walk. He was able to walk before he fell down 3 days ago. The patient says that he has a rash and pain in his groin area, and this started after he fell. He is also on Coumadin.
And he was out of town recently, so what kind of travel? With the Ebola scares that we had, we've gone through a lot of energy to establish where to put people. I suppose he wasn't in Congo because there have been a few more cases in the last month.
Right. Jonathan, that is a really excellent point.
Yeah, those things change what you do right up front.
Oh, absolutely. You're absolutely correct. So his past medical history, we talked a little bit about it. He's got diabetes, hypertension, history of PE, anxiety, depression. He's not had any surgeries, believe it or not. He's never smoked. And alcohol was not documented on the chart. In terms of medications, we talked about the Coumadin, but he's also on lisinopril and metformin, and he has no medication allergies. So we're looking at the gentleman. He's a morbidly obese, heavy guy. He's sitting there. His temp is 38.8, and blood pressure 124/60. His heart rate is 110. He's got regular respirations, and his SATs are 98% on room air. On general examination, like I said, he's a morbidly obese male. He's in some distress. He's very uncomfortable, but he's talking to you and alert. A little bit slow to answer, but he's alert and talking to you. His skin is hot to touch. He's got this right anterior knee abrasion and evidence of his fall. It's a few days old, you can tell. He's got dry mixed membranes. His heart is tachycardic, as we saw in his vital signs. Lungs are clear. He's breathing pretty easily, not any distress whatsoever. His right hip, I ranged it. That's where it was hurting him. I ranged it, but it didn't really hurt upon passive ranging. It did hurt him when I asked him to flex it. So it was kind of painful to move that hip. His abdomen is obese, soft, but it's not tender at all. And neurologically, he's really pretty alert oriented, and he's slow, but he's really with it. So any thoughts at this point?
Yeah, with a fever like that in an elderly individual, you have to start going through it, but you can't forget you got this rash or hemorrhage or whatever down in the groin, and you can't walk. Right. He's got some pain. You really have to work up two things at the same time, I think.
What differentials would you think of at this point, you think?
Well, right out of the gate, like I said, infection, it could be
Yeah.
anywhere, right?
Right.
Urinary tract infection, even in a male who's diabetic. Respiratory doesn't seem like there's anything there that's much, but again, certainly you got to look at those two main things, as in any cases when you're talking about fevers.
Right.
And then getting imaging, of course, of the pelvis and the hip. I'd probably go straight to a CT scan.
Yep.
And probably get a CT scan out of the pelvis again because of his age, because of both those things going on. As we do in the ER, we start our testing and treatment all at the same time.
Right, exactly.
So we get the cultures, we get the labs, we get to see where his INR is. We probably get a lactate with him.
Right. Any thought on the rash and the hip?
So it depends on what that looks like. My vision is he's on Coumadin. He had trauma, 2 episodes of ground level falls.
Right.
So I'm thinking of just hemorrhagic issues.
Right.
I'm not hearing that there's any type of, compartment syndrome. There could be a retroperitoneal bleed or a pelvic.
If you were actually seeing this guy,
Right.
you would be examining him, looking at his skin.
Yeah, that's for sure. I'd be able to see what that rash looked like. I mean, my first thought is it's traumatic related with the Coumadin.
Yeah, that was my thought too. Exactly. But then how did I link it to the fever? I didn't really know. How do you explain that, right? So I examined him more carefully.
Yeah. I mean, that's Occam's razor, right? You try and make everything come together.
That's right. Dr. Vasquez introduced me to that concept where the simplest explanation is the explanation, basically.
Sure. And if there's just one point,
Yeah,
right?
yeah, exactly.
So
one point.
it all comes together into one. But yeah, let's look at the rash.
That's right.
Hear a little more about that rash.
Exactly. So when I see patients, I don't always look at the skin, but then on this guy, I was thinking to myself, well, how do I connect all these dots? He fell. He's got a contusion or some sort, or he's injured his knee, but he's got a fever now. Did he fall and get it debilitated? He got a UTI or whatnot? And then I thought, oh, wait, he has a rash. Maybe he's got, some viral or bacterial or spirochete infection on his travel. Maybe he was being a naughty guy, whatever, right?
Sure,
you got all sorts of differentials running through your head when you have a diabetic and a fever, right, with a rash. So his general skin, there's no rash. There's nothing on there. So I look where the hip is.
Yeah, so
Voila.
See your note here, angry red, thickened, but includes the scrotum and penis, even though there's no crepitus, but there's perianal erythema. And a diabetic, you got to make sure this isn't Fournier's gangrene.
That's right. It was really remarkable. And I was so happy that I even looked because, it's easy when I get a patient like this to kind of just to a quick exam and then just start your workup, right? I didn't understand what was going on for sure. And then I remember that he was talking about this pain and this rash he had. So then I picked up his gown and then I was like, okay, boom, that's it.
Dangerous.
Yeah, this guy could die. I mean, was really sick, right?
So it did look like Fournier's to you.
Oh, yeah. It was really, like I described, angry red, really tender, and I've seen Fournier's before several times. In fact, most recent one was a very, very, very sick patient in his 70s, and he died the next day.
Man. Yeah. So these things like necrotizing fasciitis, it's a time to move.
Exactly. So at the bedside, we did the lactate, and it was 2.5. His white count came back 16. So his hemoglobin 12.9, hematocrit of 36.5, platelets are 207. He's on Coumadin, so his INR is 5.7. His BMP is here as shown, and pretty much the most remarkable thing is that he's got renal insufficiency, creatinine of 2.47, and his glucose is 225. His urine was negative, so he wasn't having renal failure from that. So then CT, of course, like you said, very early on, and not a surprise.
Wow. Man, great case. Jeez, Alice. I mean, you look for this stuff, right? You document for this stuff all the time.
Yeah.
Over years and years, you document for this.
That's the whole purpose of the whole reason this iCubed series started is that we have so many interesting cases that, unusual cases that come through our doors. And there's so many teaching points and things we can learn from just dissecting through the cases and thinking through them together.
Wow.
So the CT came back, and the impression is as shown here: extensive soft tissue gas, is noted in the right perineum, extending towards the right scrotal area. Associated fat stranding and skin thickening is noted in the adjacent soft tissues. There is no drainable collection. Findings could represent necrotizing fasciitis in the correct clinical setting. So, I mean, you nailed it. As soon as the GU exam and the skin exam was evident, you just, there's necrotizing fasciitis and Fournier's. Yeah.
So, this is exciting stuff. I mean, really, we go into emergency medicine to catch this stuff.
Correct.
To get it early on, to do everything we can on these cases.
Right.
And I know you, and you're calling the consultant right up front.
Yep.
So, right when you get that clinical evaluation, we're not waiting for the CAT scan and we're not waiting for labs, or even if they're delayed for some reason or another, we're not waiting for anything else.
That's right.
You get that surgeon involved right up front and work with them through the process.
The CT does come back. We do have a confirmation of the clinical impression on somebody like this. We're going through the abdomen down through the perineum, and you can see the
stars. Wow.
Yeah.
That's great. Oh, yeah.
So it's just remarkable. If we look at the image here, and I'll freeze it, but you can see the air in the buttock.
Posterior to anterior,
It's
extensive.
it's really, really extensive. And the physical exam, although it was really remarkable, belies how deep this is. I mean, you're looking at the gentleman, and you're looking sort of on the superficial external view, but on the CAT scan, you see it just goes from anterior through to the posterior, and you've got gas. As far as the buttock cheek.
Oh, yeah. It's significant. It's easily seen. And but this is a big guy, as you pointed out earlier.
Heavy,
a lot of fat tissue.
Yep.
You said there's no crepitus, but again,
it's deep.
Yeah. He's got a lot of subcutaneous tissue there.
It's remarkable. So you nailed it.
Yeah.
Jonathan.
Make me feel good, Alice.
Good job.
I'm on the hot seat over here.
Yeah, exactly. All right. This is case number 2. You will nail it in 1 second. I'm going to show you pictures.
I should hope so.
Yeah, I'm going to show you pictures in a minute, but he's a 60-year-old gentleman who comes in with a very painfully infected left foot. He says, my foot is infected, right? So it gives you a clue what's going on. He said it started really about 4 weeks ago. He had purchased these new shoes about four weeks ago, and he's not really sure how he got the infection, but he says his foot is infected, right? He says he's got no medical history. He's not on any medications. And I'm thinking to myself, okay, he's one of those guys who doesn't go to the doctor and he thinks he's healthy. But anyway, temp is 37.5. Blood pressure is 145/79. His heart rate is 128. Yeah, something's going up. Yep, something's going up. Respirators are 12 and his stats are 97. So our general exam on this patient is, he looks okay. He's a normal looking guy, normal weight, I would say, I guess. He's cooperating, he's talking to me, and then he shows me his foot.
There's the moment of truth. Oh, yeah.
Oh, my foot is infected.
Yeah. It's been infected for a while.
Yeah.
4 weeks, he said.
Right. It started 4 weeks ago, he says. So I'm asking, are you diabetic? Do you have peripheral neuropathy? No, I don't take any medicines. I don't have any medical problems.
How many times have we heard that?
Yeah, I know.
And then the nurse says, oh, yeah, here's his med list. So
he actually didn't have any meds.
It's supposed to be on insulin. Right. It's supposed to be on metformin.
Right. So he actually did not have any meds.
Wow. So.
Yeah.
And he wasn't diabetic.
No. Well, his blood sugar was high. It turned out he was diabetic, just non-compliant. So, yeah, the pictures, what do they say? Pictures
worth 1,000 words.
Worth 1,000 words, yeah. So, you've got the gangrenous areas, you've got the vesicles, you've got the cold foot, and erythema cellulitis. These are images. I love images, so here we go. Look at that.
All the way, gas all throughout.
So on this gentleman, as opposed to the other guy, I can feel the crepitus. You can, you see how superficial it is.
Sure.
Right.
Oh, man. So I wonder if they just didn't go straight to a BKA.
So exactly, actually, he went, I transferred him, and I found out from his wife later on that he had a BKA.
Oh, my stuff.
Look at that. It's just so...
all the way up.
Crazy, right? So don't ignore your foot infection.
No, don't ignore it. You take your medicine.
Take your medicine like it's supposed to. All right. So, Jonathan, as you know, we have 2 learning focuses for each of my iCubes because I just want to focus us down to the learning points and not to have to juggle too much in our brains. Learning point number 1, what do you think?
Neck fascia.
Yeah. It's one of those true emergencies you don't want to miss, right? We're always looking for it. Like you said, we're studying about it. We're looking for signs. We're x-raying and we're CTing to looking for it. And it definitely exists out there. I reviewed a few different blog posts, and this is a really useful one from EM Docs. It is titled Necrotizing Fasciitis, Pearls and Pitfalls. So let's go through that. Necrotizing fasciitis, what is it? It is a deep necrotizing soft tissue infection of the muscular fascia. It is associated with tissue destruction. It exhibits systemic toxicity and has very high mortality and morbidity. Necrotizing fasciitis is rare, but it is deadly. Very high mortality, 25 to 35% mortality. It is most common in extremities and perineum and genitalia. It usually starts from a break in the skin, but apparently 17% of these cases in this study didn't have any break in the skin. And early diagnosis and surgical treatment offers the best outcome for these patients. There are 3 types. So type 1 is polymicrobial gram-positive cocci, gram-negative rods, anaerobes. Type 2 is a monomicrobial, which is group A beta hemolytic strep, and sometimes with Staph aureus. And then a 3rd type, gram-negative marine organisms such as Erythema and vibrio. That I did not know, actually. So type 1 is what we had first, the first case, Fournier's. These tend to be in the older gentlemen, older patients, diabetic, they have liver disease, peripheral vascular disease, and recent surgeries. They tend to be immunosuppressed. Common case is Fournier's, and then Clostridial gangrene, which is the foot that you talked about, causes the gas gangrene. Yeah. Type 2 is monomicrobial. These tend to be in the younger patients, IVDA patients, traumatic, can start from lacerations, they can start from burns, and it actually can be associated with toxic shock syndrome. A 3rd type of neck fascia is your gram-negative marine organisms that usually occur and they enter through open wound or break in the skin. Occurs when you're exposed to fresh or salt water. The etiologies are Erythema hydrophila from fresh water, Vibrio vulnificus in seawater or from oysters. So be careful when you go there scuba diving. Don't cut your skin.
Yeah, I was going to say, I was thinking about that.
And another really useful article is this one on EM Docs as well. Because this is such a critical diagnosis, we really have to be vigilant, right? So this article was very helpful. How do we misdiagnose and mismanage necrotizing fasciitis? So 7 ways we miss the diagnosis of neck fascia. Number 1, unreliable history. So you're talking to the patient and they tell you that maybe misleading history and doesn't really trigger the thought of neck fascia, or they can't tell you the history. They're drugged up or they're old and demented, right?
Yeah.
Number 2.
Febrile and altered, yeah.
Yeah, febrile altered, and they can't really tell you. Number 2, reason that we might miss the diagnosis, exam is unreliable in that we just anchor on the red, hot skin, and we don't think beyond that, right? We think, this is another case of cellulitis. Number 3, so failure to complete a full skin exam, especially those who cannot give you history. So that I was at risk of doing on my Fournier's actually, because I was kind of trying to get through this case, and then I was thinking, okay, what is putting all this together? And then I remembered that he had complained of a rash and that hip. Because at first, like you thought, it's traumatic, he hurt his hip. And then I remember he had a fever. Okay, how do I put that all together?
Sure.
Number 4, failure to consider uncontrollable pain and anchoring on the pain seeker. So this is, I think all ER doctors are very subject to, is because we get kind of calloused and we kind of get numb to the fact that people are complaining about pain. And then we get, anchoring on the young, especially the young people who are seeking pain medication. So we have to be careful and step back a little bit and not be so judgmental and biased, right? Mm-hmm. Number 5, reliance on the labs. And there's something called the LRI-NEC score that's out I've never heard of, but I
don't know what that is.
Yeah, it is a score to kind of help you decide whether this is neck fascia or not. But essentially, when I read up on it, it's really not that reliable. Mm-hmm. So this point is basically saying, we over-rely on that's Fournier's score. It's not Fournier's. We over-rely on the neck fascia score and rely on the labs. So number 6, too much reliance on the imaging for ruling in the disease. So if you look at the image and you think, okay, well there's no error there, you don't correlate with the actual physical exam or how sick the patient is systemically.
Right. But then the last one, who hasn't been caught with this? The surgeon says, tell me about it in the morning, put it on the list.
Right.
I don't have to come in now, do I?
Right.
And that's just a hard thing because you want to work well with your colleagues. You want to work well with your consultants. Yep. You certainly don't want to
antagonize.
Yep, antagonize or provide unnecessary work that's out there.
Right.
But definitely, this is one that you just can't miss, and got to have them come in.
Right.
And let them know what your concern is.
Any suggestions how you will navigate through a difficult consult? Where you really feel like you need to see this guy?
You do. It's just persistence. It really does. Just persistence. Let them know that you really have this concern. You need their expertise involved now. Yeah, great. That's what I tend to do as well. I may call them a few different times quickly instead of getting into an argument, Sure.
All right. So this other section of the article, where do we fail in the management of neck fascia? Okay. So number 1, we forget sometimes that this is a surgical disease. It's not medical. It's not something you park on the floor, right? Number 2, we fail to provide broad spectrum antibiotics. The Infectious Disease Society of America recommends Vanco or linezolid plus the piperacillin tazobactam or a carbapenem plus clindamycin. So there's 3 antibiotics, right? Triple antibiotic, broad spectrum for neck fascia. Number 3 way we fail to manage neck fascia is to fail with the resuscitation and with fluids and vasopressor. Maybe we put that on a little too late, That's what this point is referring to, I suppose. And then number 4 way we fail to manage the neck fascia is that you may believe that IVIGA and hyperbaric oxygen are the cornerstones of therapy. It is not. Yeah. It's a surgical disease.
Yeah, fluid's a big important issue there. They lose so much.
Yeah.
And they're going to lose more after they go to surgery.
Correct. Learning focus number 2 is Fournier's gangrene. So we're going to talk a little bit more about it. This is a short segment. There's just a few unique things to talk about with regard to the Fournier's gangrene. Fournier's is a type 1 necrotizing fasciitis, as we talked about, those different types. It's polymicrobial. Diabetes is a major risk for patients who get Fournier's gangrene. Early aggressive intervention is critical and life-saving. Surgical debridement is definitive treatment on these guys, definitely. Early administration of broad-spectrum antibiotics, crucial, of course. And the hallmark of the Fournier's is intense pain and tenderness in the genitalia. So that's definitely my experience in my career. Have you seen a Fournier's in your career?
I've seen probably 3, so not a lot. The other thing you talk about the surgeon, because you need a colleague, you need a partner to get this taken care of.
Oh, totally.
And, the surgeons always used to joke, at least when I was going through training, about the treatment is always cold steel. And so, I don't know, playing on their energies of youth, because it isn't these antibiotics that are going to save their lives. It's getting into the OR.
Exactly. So for Fournier's, the progression of the disease is fever and lethargy, intense genitalia pain and tenderness. The pain increases and progressively the genitalia becomes more and more erythematous, and the skin becomes more and more thickened and erythematous. This becomes then a dusky appearance of the overlying skin with subcutaneous crepitation. Then there's gangrene, and then there's purulent drainage, and then sepsis. Yeah. Well, that's it. 2 cases.
Alice, great cases.
Neck fash.
Don't forget.
What?
Yeah, no one should forget.
Oh, I see. Oh, yeah. This is definitely, these are cases that you definitely cannot dawdle with. You know, you are tasked to make a big difference on these people's lives. So, as I was saying, you know, these cases that I present just reaffirms and validates our choice of our career and profession, and validates that what we do in the emergency department really, really does matter.
It does.
Yeah.
You make a big difference in people's lives every day.
Yep. Well, thank you, Jonathan.
Thanks, Alice.
Appreciate you coming on and talking to me about these cases. Thank you, everybody. Thanks for listening this month and watching this month. I appreciate your support, and we will see you soon. Next month, in fact. Bye.
Bye-bye.